unlock the ability to dramatically increase access for existing rare disease indications, to unlock previously untreated rare disease indications, and for the first time, offer the promise of bringing gene therapy from the realm of rare diseases into mainstream, and then a little bit of a forward-looking view of our vision in terms of building the company. So let's start with the opportunity that gets unlocked by this unprecedented combination of features, redosable, long-lasting gene therapy with high-capacity manufacturing. This is a trio of characteristics, of course, that's been in sight for this new modality for the last 20 years. And each modality is touching different components of this trio. AAV as a modality undoubtedly hits long-lasting expression, but has no capacity manufacturing and it's not redosable. mRNA, by contrast, does not have long-lasting expression, but has high-capacity manufacturing and is redosable. And gene editing, by and large, depending on the delivery, really tracks with AAV gene therapy being long-lasting but not redosable, and also being hampered by low-capacity manufacturing. Nevertheless, at this early stage of maturation of gain-of-function gene therapy, we have $50 billion of allocated market capitalization, a very large space with lots of opportunity to both disrupt and grow it. For any company that's able to create an appropriate, scalable, translatable combination of these three features, and that's exactly what we've set out to do here at Generation Bio. So let me walk you through how our platform unlocks each of these three features. And let me start with redosable delivery. We have a novel, biologically cell-targeted lipid nanoparticle delivery system. We have a proprietary closed-ended DNA construct, and we've developed a proprietary capsid-free high-capacity manufacturing platform that underlies these first few features. To give you a flavor for how these features have come together in terms of a snapshot of the data, first I'm going to show you the ability to redose. This is an immune-competent mouse being dosed at day 0 with factor 9. A single dose results in about 8% factor 9 expression. We give the same dose again at 30 days, and you can see that expression exactly doubles to about 16, 17, 18% with that second dose. This is the experiment you cannot do with AAV because of the adaptive immunity. It's capsid. It underlies one of the key features, incredibly clean chromatogram showing the over 99% pure drug substance that has happened at 1 liter, 50 liters, and now at 200 liters GMP capacity, on the way to really no upward ceiling in terms of upstream capacity. We really have the ability to go right to 20,000 liters on this platform. Now, what happens with this combination of features from a clinical perspective? Redosing allows you to include many, many more patients. Many patients today don't access AAV because of pre-existing antibodies. That is not the case for LNPs, so it increases the access for those patients. It allows you to titrate each patient to the right level. Many patients, when they get a single dose, don't get to the level of expression they're hoping for, their clinicians are hoping for. Crucially, it enables treatment in childhood when it matters most, because you can redose to accommodate the growth of the liver, for example. And finally, for previously treated AAV patients, we can boost and extend the efficacy of their first doses. From a clinical perspective, you obviously get the same benefit of very low dose frequency. And finally, as I said earlier, the high-capacity manufacturing side of the equation lets you really consider bringing gene therapy into a more mature era when it can be applied to mainstream diseases. What does that mean commercially? It means that in existing indications, you have the opportunity to dramatically increase the number of eligible patients who can be treated by essentially offering the opportunity to redose and titrate for each patient to a targeted expression level. In terms of opening up new indications, it's the opportunity to move into new rare diseases, diseases whose genes or combination of genes that are too large to fit inside existing technologies. And it's obvious that if we can move into mainstream indications, the market opportunity to deploy this very large capacity transgene delivery system on a high capacity manufacturing basis for the first time makes it possible to think about bringing gene therapy into the realm of day-to-day practice for very common diseases. So let's talk a little bit about how this platform works. And before I do that, I want to give you a sense of how we're building the company from a therapeutic area perspective. We're going to start in the liver. We're going to build a deep portfolio in the liver. And in parallel, we'll be exploring, and I'll give you some insight on that today, the application of this platform to additional tissues, specifically skeletal muscle, and retina. Within the liver, we have a very deliberate strategy. We're starting with PKU and heme. These are very large, prevalent, highly pediatric-focused indications that continue to have unmet need. They have very strong, very clearly defined regulatory biomarkers that are also endpoints, and there are really abundant patients to be had in the development phase. Each of them in their category of liver disease leads to very natural, deeper follow-on indications where the unmet need is even greater. For example, Wilson disease, Gaucher, or HAE. And as we develop the platform and mature within the liver, we're seeking to move into multi-gene constructs to address more complex diseases like alpha-1 antitrypsin. And it's very easy to see down the road when the targets are defined, even very large indications. Their biodistribution occurs at the mercy of host protein bindings or host protein opsonization. The reason why LNPs so far have only successfully been used to deliver cargo to the liver. We really seek with this biologically cell-targeted system that we've invented to conserve species translation, to remove background host protein binding as the driver of biodistribution, and to replace it with a very specific biologic target ligand pairing that can be specifically used and swapped to target specific tissues and cell types. This opens for the first time the opportunity to move beyond targeted lipid nanoparticles. But let's start with the liver. The ligand we've chosen, not surprisingly, is GalNAc, and its target is the ASGPR asialoglycoprotein receptor. Based on decades of work at Alnylam, we know a lot about the species conservation of ASG instilling inflammation. And in the bottom of this expression graph, you can see standard LNPs barely get above baseline in expression, not because they can't deliver cargo, but because the inflammation is so severe and so early that you get an almost immediate degeneration of the retinal. See that in the bottom left of this slide, standard LNP treated in infancy or early childhood with these key genetic disorders. And for those patients who have pre-existing antibodies to AAV, they're eligible.
Why did you pick liver disease as your proof of concept, given that I understand it's unmet need, but there are a lot of people who try to address this?
That's true. I would say today there is no gain-of-function gene therapy equivalent to what Alnylam has achieved for knockdown, which is the broad, robust ability to repeatedly address compartments. So we believe there's something no other platform has been able to do for gain-of-function gene therapy treated by producing a protein in the liver. And as I started off